Let's go over rotator cuff tears. We can think of this group as a sleeve of muscles that primarily perform rotation, and we're going to be talking about what happens with a failure of that system. Today we're going to be covering the whys, why the cuff exists, why it fails, and why it feels the way that it feels for patients. Also, why the treatment works. The shoulder is one of the most mobile joints in the body. It can move front and back, side to side, and it also has rotation. But that mobility came at a cost. If we think about the glenohumeral joint, we're going to be thinking about a T, which is the glenoid fossa of the scapula, and the golf ball sitting right on top, which is the humeral head. The glenoid fossa can be broken down a little bit further, glenoid meaning socket-like, and fossa being a hollow or a pit. And the body built a dynamic stabilizer in order to keep the golf ball on top of the tee. And the sleeve of muscles that gets the job done, we refer to as sits. S being supraspinatus, supra meaning above, spinatus referring to the spine of the scapula. This sits on top of the scapular spine. This initiates abduction and is also the most commonly torn. Infraspinatus, infra meaning below, so below the spine of the scapula, this performs external rotation. T being the teres minor, teres referring to a round muscle and minor being the smaller. Where there's a minor, there's a major. This also performs external rotation and works with the infraspinatus. And lastly, S for subscapularis, sub meaning underneath, scapularis referring to the scapula. So this lies underneath the scapula, and this is the only one that performs internal rotation. The shoulder sacrifices stability for mobility, and the rotator cuff is the balance. There are two ways for it to fail, and there's also one more reason why it's typically always the supraspinatus. The first way being acute. This is when a force exceeds what the tendon can handle. So thinking about a traumatic incident or you're carrying a heavy load, these tears happen in a singular event. And then you also have degenerative. This is not a singular event. This is years of repetitive compression happening over time, typically in older individuals with jobs that require repetitive overhead reaching, or it could happen in the younger population in intense shoulder sports such as a pitcher in baseball. This is when you just reach one more time and then that's what does it. Think of a rope fraying over time. Now, why is it the supraspinatus that typically gets injured? So we have to look at this anatomically. The supraspinatus lies in the subacromial space, sub meaning under, acromial referring to the acromion process, and this is the roof of the shoulder. And the supraspinatus runs right through that space. So every time you have elevation, you also have compression. And this happening hundreds of times a day, especially if you're working in a profession that requires it repetitively, can cause tears in the tendon. So you have the tightest space with the most compression, which is typically why it always leads to the supraspinatus. So first you have the painful arc. This is 60 to 120 degrees of abduction. At 60 degrees, you have peak compression, and it stays there until 120 degrees. The arc is not a symptom to memorize. It is the peak compression zone made visible through motion. Next, you have night pain. And typically, you'll always hear patients talk about how much trouble they're having sleeping at night when it comes to pain with the shoulder. When you go to sleep, everything starts to relax. So all the muscles that are helping you keep that compression off the inflamed tendon is no longer supporting you when you're sleeping. And this actually makes it worse when you're sleeping on that side. So now you have additional compression happening on the inflamed tendon. So this is why rest makes it worse, because the joint loses the one thing that is managing the pressure. And lastly, you have weakness with abduction and external rotation. We talked about how the supraspinatus is typically the one that's injured when it comes to a tear, and the supraspinatus is responsible for abduction. So if you have a tear and the muscle performing the initial abduction, then you're going to have weakness with abduction. The infraspinatus and the teres minor produce external rotation, so a tear in those muscles will cause deficits in external rotation. With a tear in the muscles, now the action is gone. This isn't a neurological thing, it's a mechanical one. Every symptom has a reason. When the rotator cuff fails, the body doesn't just stop moving. it finds a way to get the job done. Ways that it finds that is with the upper trap activating a little bit more to help with the shoulder lifting, the trunk can lean a little bit more, and momentum can replace muscle contraction. The arm can still reach overhead, it's just not happening through the cuff. The body wants to take the path of least resistance. And unfortunately, the path of least resistance is not having the muscles get the job done, it's having the body compensate for it. It looks like effort, but it's not recovery. There's one thing to keep in mind when treating the shoulder, and that's the scapulohumeral rhythm. Scapula referring to the scapula, and humeral being the humerus. There's a coordinated dance happening between the two every single time you elevate your arm. There's roughly 2 degrees of glenohumeral movement for every 1 degree of scapular rotation. And when the cuff tears, this dance also breaks. The scapula starts moving a little early, the upper trap starts to compensate, and the ratio disappears. The treatment that we implement does not just rebuild the cuff, it also rebuilds the rhythm. So the compensations no longer need to happen. We do this in 3 phases. And the first phase is protection. When someone undergoes a surgical repair, you're going to be given a list of protocols either by the surgeon or by the clinic where you work. The main goal here is to protect the tissue while it heals. You have load restrictions, you have range of motion restrictions, and the biggest thing you want to work on here is patient education and mobility of unaffected joints. The supraspinatus is in the tightest space in the shoulder. It needs that time to heal before it can take any load. There are no shortcuts through this phase, and unfortunately you're going to have some patients that just want to skip this altogether. But it's your job to make sure that you protect the repair. Once you get through the protection phase, you go into the restore phase. You want motion before load, or you want to work on mobility before strength. You want to work on passive range of motion first, into active assisted range of motion, then active range of motion. Scapular stabilizers here are going to help with your serratus anterior and the lower traps. You can't strengthen a shoulder that has nowhere to go. So you want to restore the range. This is where patients start feeling a little bit better, and you're going to have to keep educating them to make sure that they don't skip ahead on their protocols and work on this one step at a time. And finally, the load. There are still some protocols that you're going to want to follow. Some protocols will call for specific exercises at certain times. Otherwise, you can get a feel for the patient and talk to your supervising PT in order to find out what exercises are appropriate for your patient. Starting with some isometrics so you can start regaining some strength. You can also work on the external rotators with side-laying external rotation. You can do some scaption as well as some TheraBand work. Even if the patient starts feeling better, education is happening at every step of the way. And when you're starting the active range of motion and the loads, this is when you're going to start wanting to watch the scapula. What I do personally is either if I can, I place them in front of a mirror and let them know to lift their arm into scaption. And as soon as they start seeing their shoulder hike, they can't go past that range because now we're no longer working on the shoulder mobility and strength. We're just working on the upper trap and make it look like they're making progress. If you don't have a mirror, that's okay. You can just work with the patient and just keeping an eye on them and let them know, hey, this is as far as I want you to go, until we start rebuilding the strength and the shoulder can guide you the rest of the way, not the upper trap. If the scapula is hiking early, then the cuff is not being properly loaded. The body is going to want to take the path of least resistance, and it's our job to rebuild that rhythm and rebuild the dance. This is why it works. We're going to leave a study guide for you guys in the description below, so be sure to check it out. But there are a couple things I want you to remember. The shoulder sacrificed stability for mobility. The rotator cuff is the balance. You have the tightest space with the most compression, and this typically leads to the supraspinatus getting injured. Every symptom has a reason. The body wants to take the path of least resistance, so we rebuild the rhythm. That is why it works. Know it on the exam and recognize it in the room. We'll catch you next time.